here's the NCCN Guidelines looking at when Bev is used up front. And, I would have to say that the BRCA1 or 2 wild type are unknown. I think this is the little box, up top here that Bevis plus olaparib, I think, very bright people sitting on these panels deciding some of these guidelines, but I think they were thinking that probably Palo was going to get an all-comers and ITP and, the FDA, which I think I was surprised. I was happy because I do think we need to move to biomarkers, but I was surprised that they kind of cut out the HRD. So it'll be interesting, just like you said, Shannon, are they going to go ahead and stop
revise that? Yeah.
Recommendation. But to me, I think what this does is exactly what you guys have said. We have lots of options, and depending upon side effects, depending upon how patients are doing, will give us options. We actually had a patient who was on bevilaprib based off ESMO, and she's had 2 blood transfusions and dose reduced, which I was surprised about. And so our recommendation is she's BRCA2 mutated in her tumor, so we're going to switch her over to another PARP and take her off Bev, but to keep her on PARP. So I think that giving us these options, I think, are what's key. Side effects drove her off the combination. So being a BRCA mutation type of patient, I don't think any of us are willing to not treat her, or at least try to treat her with PARP for a little longer. Any thoughts on these guys?
No, I mean, I think you covered it. I think that it'll be interesting to see if anything changes now that we have all the indications. And then, of course, we don't really get to talk about it, but I feel like it's important to mention just the Velia data that, we mentioned the trial design and the chemotherapy with the veliparib. If that does get an approval, then we'll have to kind of come back to this situation and see, okay, where does that fit in for all these patients? But for now, without an indication, we're just, we're making the decision between these 3 agents.
Yep. Excellent. Okay. So if this patient was BRCA1 or 2 wild type and HR-Proficient, what would you recommend for maintenance therapy after carboplatin, Taxol, Bev for primary therapy? Options: Bev, bevacizumab plus olaparib, niraparib, observation, or clinical trial. I think anytime we talk about clinical trial, that really should be where we go.
Yeah.
I mean, we've great strides in BRCA mutated patients, great strides in HRD. But to me, we have first open. We hopefully we'll get duo reopened. We try to put patients on Athena. I think the bottom line is that we've made great progress. And to me, I think if we can get patients on clinical trial, that's what we need to do. And so to me, I would still say clinical trial. Most of our patients, unfortunately, don't go on clinical trials. So HR-Proficient. If this patient had a lot of ascites, I would use bevacizumab. If the patient didn't have a lot of ascites, I would probably switch over to single agent niraparib and do some type of switch maintenance. I would not use bevacizumab olaparib. So.
Yeah, I think for her where we started Bev, I would just continue bevacizumab. And then if I hadn't, I would, talk to her, as I mentioned before, just review all those data around the niraparib single agent and try to make the best decision possible. But I agree, the clinical trials, especially for this proficient group, is really what we're hoping we're going to see more of an impact when those are all reported out.
Yeah, I would agree. I would leave this patient on Bev as maintenance. I don't think this is a scenario where you're getting enough mileage out of your PARP to add it. I worry about some of the cost effectiveness analyses that have been done looking at this preliminarily. So I think I would just stick with single agent Bev maintenance in this scenario.
So we all agree the FDA got it right and did not give the bevacizumab olaparib an ITT all-comers, so nobody wanted to add olaparib on. So very nice.